Good morning
Good morning.
to our Mediquest, the faculty, and good morning from Mount Sinai Cath Lab for our episode number 24. So this marked the end of second anniversary, so 24th episode of this tremendous learning with Mediquest. Have been working great feedback which we get from our Indian faculty and all my staff here with Dr. Keeney on the left side and our fellows here, Gaurav and Rajiv, and a lot of our Cath Lab staff, which I think all well known. And I'm sure nobody will remember the name if even we say, but faces, most important, all those faces are constant. And then, of course, we have our researcher, our echo, or imaging actually, expert, Kiski and our Pablo and our other nurses all there. So Anu, with that note, we wanted to just show this is really a complex case of the LED diagonal bifurcation, and we wanted to just show the next level of the complexity for this case. So this is in collaboration with CCC Live, cases.org, Cardiac Cath Lab of Mount Sinai with CME from Mediquest, India. So these are our disclosures, nothing for both myself and Dr. Keeney. And then we actually have two faculty, the guest faculty, Dr. Anil Poddar, whom I have interacted a few times, and then Dr. Vedanti Sringare. So the little bit about both of them. Dr. Anil Poddar is connected to many hospitals, and of course he's CCFS CAI. And more important is with the Shushruth Hospital, and very busy interventional cardiologist involved in many the cases, many trials, research, and well known for performing complex coronary interventions, which the new name we call it a CHIP, and of course doing quite a bit of structural procedures also. And Dr. Vedanti Dilip Sringare is a welcome, and she is a interventional cardiologist, and I saw that from her bio that tremendous experience in the structural interventions in imaging and so, which is the next frontier. With that note, we go to our case. We have a live case from here for 1 hour, and then we have OCT guided complex left main and CTO by radial route, and then with both our faculty, Anil and Vedanti, and then we have a interactive panel discussion. So this is the case, basically the case number 24, 71-year-old male. Didn't have much history until a few months ago, presented with the class 1 angina and has a positive high-risk MPI for multivessel ischemia. He's a smoker and hypertension, hyperlipidemia, which are controlled. Values Anu actually has written down. How things are there?
Yeah, patient's LDL 72 on a Lipitor of 10. And again, I think there could be a discussion. Should we go LDL lower than that? HDL is low, actually, 29. And we know, I mean, statin do not increase the HDL more than 5% or so. They really have to exercise to get the HDL up. Triglyceride is 52, but hemoglobin A1C is 5.5.
Yes, totally non-diabetic.
Yeah. With the PRU of 126.
Yeah. So basically now, as you know, that we also monitor, and we have published actually another paper is in publication about SAQ score. SAQ 7 is more objective rather than subjective. And basically our all nurse practitioners for elective cases, those 7 parameters of the Seattle Angina questionnaire, and anything near 100, patient has minimal symptoms, 0 means with severe symptoms. So this patient's symptoms were just mild, and that goes with the class 1 angina this patient has. EF was mildly decreased, actually 45, and ischemia. So patient actually was, after last PCI, was added on clopidogrel. Before that was only taking amlodipine and atorvastatin 10 milligram. So had 2 vessel disease, and at that time underwent PCI of the RCA, and now for the complex PCI of the LED diagonal 1 and 2 bifurcation, whether use a rotational atherectomy or so. With that note, I think we'll just come back to the angiogram, please. Yeah.
So EF EDP was about 12, 45% EF. And the right coronary artery where we had the previous PCI site looks okay, proximal RCA. And you do see the LED if you see there from subtle to subtle, some collaterals, you can see the LED filling.
Yeah. You don't see another view. Yes.
Yeah. So which is the best view? Always you try to see cranial, RAO cranial. You see the late filling, but I think this is where we can see the LED. After the proximal, you have some disease, but more important is after the large first diagonal and the septal, you can see some calcium, which is probably adventitial, and then I would say subtotal to total. More important, the vessel itself is, it dips down, and the lesion has angulation of about 45%. So that's why it's probably challenging. Which wire can we use?
Yeah, see, and then after the lesion, actually, if you can see, there is a diagonal originating there. That's a D2. So proximal LED about 60, maybe 50%. Then subtotal mid LED D1 is already 70%. And after the subtotal LED, there is a diagonal, which is also badly involved, about 80, 90%. Whether we need to do a mini crush of that diagonal, we need to see how big that is. So that is our plan. So now, with that note, I just take the opinion from Anil and Vedanti, and please ask our viewers to ask the questions in the chat box, that how would you deal with this? There is some calcium, as you saw it in the RAO caudal view, on the top surface, but and it's a very eccentric, complex lesion.
Yeah. Good morning, Samin sir, and
Yes.
good morning, Annapurna. Very complex case indeed. And there is a lot of bend at the site of subtotal occlusion. So wiring would be a challenge here. But how about taking a workhorse wire as a first, attempt?
Yeah, so very good point. So what we are doing is, what we have been teaching, the fielder wire and the fine cross. So that is what we are using now. And the question comes with that calcium on the one wall. Is it adventitial calcium, the superficial, or the deep calcium? If superficial, maybe it's less of an issue, but that's what we are going to do now, that cross the lesion first. And this is where the guide is 7 French, VL 3.5. And it's pointing a little more selectively to the very short left main.
Yeah, so maybe I need to get.
But I think whole case is the wiring. Yeah.
Wiring.
Yes. Yes.
Okay, so we have a fielder fine cross. This is a fielder, regular fielder. So I'm at the lesion. I'll just advance the fine cross gradually, slow, and then see.
Anything will be fine.
Okay.
You can magnify a little further, right?
Some die. No, it's too much. Go.
Yep. So this is, we know that it dips down and takes the turn. You want to go to some other view? Epicranial now?
Okay.
Yeah. Okay, we are going to the epicranial. It looks like the first part.
I think I'm in the LED now.
Yeah.
Why you have
Okay.
magnification? We are in
So
the
you're in that diagonal. Yeah. Good. So let's put the big diagonal. Good. So what do you want to do now?
I will change to run through, go into the diag, and then...
This one will go to the diagonal also.
With this wire?
Yeah.
Or we dilate and then get the short run through into the LED.
Okay.
You have the
So,
300 run through?
Okay. So you said that, take a picture now. You want to bring back the fine cross. We always say that in the total, subtotal, you put a wire, your device, then take a picture, because you could be in some small branch. You want to be sure that you are in the main branch. Yeah, we're in the diagonal. So I would say, yeah. So why not we just go with the side by side into the LED, another wire? No? Okay. Anyway, we got the exchange length.
I think we dilate first and then get into the LED.
Okay, good.
So the fine cross went easily. We can exchange to a 300 wire, which we normally use a run-through wire.
Yeah.
Give me a regular 300 run, 180 run. Oh, you want to go fielder to the LED?
Yeah.
Let's see.
So now question comes very important. Maybe we can ask the poll of the anybody our viewers can say, should you dilate now or you want to go into the LED first with the wire
Yeah.
introducer? Anil, what would you do now?
That,
So I think this is a good exercise. I mean, good talk. You went into the LED now, no?
No, I was thinking I would do that, but then I was through the run through, right? I was through the fine cross.
Yeah.
we have secured one wire into the diagonal, so it we are safe anyways.
Yeah, no, yeah, that's absolutely correct. The only question will be that proponent or the con of that could be that you dilate there, you may do a little more plug shift into the Austrial LED, and your further wiring will be difficult. Let's say, let's ask Vedanti what she will do now. And then we'll ask, like, not only that, then Anu will decide, she already has a plan what to do. What would you do? And any other different opinion by our other people. So now you want to go into the LED or you want to dilate a little bit first?
I think
So you like to go to LED first, right?
Yes, sir. I will like to see, have one wire in the LED too.
Yeah. Good.
Okay, let's dilate the LED, right? Then I get a run through. Get me a new fielder. Yeah, this
Okay.
fielder is gone.
Yeah. Okay, let's see. Show
What do you
them.
want?
No, I just wanted to show this picture once again. So this is our wire. So diagonal, I would say that I would definitely make it a little extra effort to put a wire into the LED because that's really the money is. Even if by some chance we don't get a great results on the diagonal and we do a D1, which we know also tight disease, although that's not truly at the ostium, but it will be reasonable to go. Go back to the caudal view again.
No.
Okay.
Neither.
So that we need to go into that LED. So LED has to be done before we dilate. So I think that will be the common teaching. Now, can you do it just before the bifurcation, a small balloon? We had to have then a small balloon before the bifurcation to give a little room for the wire. But I would say that give one attempt first, wiring the LED now. And then if not successful, then maybe decide to go into the dilate that area. So this is where we are now.
No, there is no question.
Okay.
Yeah.
We have not received any questions from short box right now. But
So, how was the feel of the lesion while crossing the first wire, which went to the diagonal?
No, it was
Balloon,
very smooth. Yeah.
trio balloon, right?
Not that there was, like we said, I think the calcium that we saw was adventitial calcium. Yeah.
Yeah, that is the reason.
Yeah.
Yes.
So we had the next round of wires ready. One of the wire we wanted to show was the anti-grade, which was the Mongo. There are two kind, Mongo MG or Mongo ES extra support wire. Tip load is about 3. It's almost like a fielder in the sense it is a polymer jacketed wire with the hydrophilic coating. But what the Ashahi keeps saying about Mongo wire is that in this kind of tortuous subtotal to total vessel, exactly the way these lesions are, that wire keeps the curve that you made. Many times what happens with this wire, you have a curve, you try to cross and then you're not able to come out of the distal.
Yeah, curve is
So
lost.
that is why you need to have that Mongo wire was best. That was the one I would have tried. But fielder did the job. Okay, down.
Go 2 millimeter further.
That's good.
Diagonal wire, pull back a little bit. Good. Go 2 millimeter further. Okay, show the, after this, we'll show the angiogram and then we'll show the slides of the Mongo wire. And tell us a little more because a lot of people don't know about Mongo. It is a new Asai wire.
It has been
It has been there, okay.
for the anti-grade.
But is it available in India?
it's not yet.
Yeah, okay. Wow, good. Okay, show that Mongo wire now while we are deciding.
I don't know.
2.520 diagonal.
Andrew, you have the slides ready?
Okay, right.
Okay, yeah, this is what we see. There are two kinds, MGES. They both come 300 as well as to 180. And other thing that I want to also highlight that the guide wire app that we have has all these wires, but important is, I think, when to use which wire. That is where we also have a lot of cases there telling about which kind of cases, what kind of lesion, what kind of wire to use. So let me go back here. Why Mongo would have been a better wire choice here. So in many of the, I mean, the toughest CTOs would be in the circumflex, subtotal vessel, total vessel, because of or the way the OM, everything takes a curve, you need a wire. So the stiff wires do not take the curve of the vessel. So in this particular case, if you see here, it dips down and then you have to, it goes up. So that kind of angulation, you need a wire that will make that kind of a curve of the, when you enter the proximal cap of the CTO. And if you see here, this Mongo wire exactly has that feature that it will keep the shape, go through the CTO, traverse the CTO, and then come at the distal cap of the CTO. Yeah, I want to show that also, yeah. And wow, what is the reason I think Ashahi talks about that wire is the next slide that they're going to show. Okay, they're going to show that.
So now,
that too, ES and MG, we used MG, not the extra support. So tip load is 3 and very important, not tapered. Remember, many of the CTO wires are tapered tip and they do have a hydrophilic coating. So a good thing about hydrophilic coating is that they traverse the lesion very easily, especially if there's calcium. What is a bad thing is that your tactile sensation feeling could be slightly different or less when you have a hydrophilic coating. So he's going to show the other feature of the Mongo.
And show the hemodynamics on one side. Good. The patient is tolerating fine. And yeah, anticoagulation is?
We have Angiomax.
Yeah, bivalirudin. And now bivalirudin with the Bright 4 trial positive data may come back again. Very positive, same 1% decrease in mortality and rather decrease in stent thrombosis. That's why they're tremendous, although done in China. So many of the things which are done in China are not applicable to rest of the world. Because I think so that is one of the criticism of the editorial was of the trial. But okay, yeah.
So if you see many of the wires, when you are going through the, I think the main reason the Mongo wire was created is that you go through the subintimal track, and once you've gone through the subintimal track, you want to do the re-entry, you need the tip load. That is why you see that when you're going through the subintimal track, many of the wires lose their tip, but here Ashahi Mongo ES that keeps that tip the way it is. And I've seen it in the cases that were used, even though you have gone through the tortuosity of the vessel, the tip has been maintained with this wire. So I think this was a good case to show that when you have a tortuosity angulation in subtotal total vessel, especially you have a tortuous RCA circumflex, this is a good wire to try as a initial wire. Same tip load is only 3. So if you want stiffer, at least you can traverse through the CTO, and then you want to do our final exit through the distal cap. You can use a stiffer wire.
Yes. So some question
for EDR, right?
Go up.
I'm sorry. What did you say, sir? We couldn't hear it.
Tighter knuckle for EDR.
Okay. Yeah. So there, as you can see here, what we are going with a diagonal 2.520 balloon. Open the diagonal, and then we decide what we need to do here. Because to me, I think that D1 is bigger. If we do mini crush, probably D1 we do mini crush. Go a little further also. Yeah. Just hold on.
Why D1? Down.
You want to go a little further here? There was a disease further down.
No, I think let's take a picture and decide.
Yeah.
One branch we try to save.
Yeah. Austin, go a little further. I think we need to go a little more, a little higher pressure. See the D2 has, it's okay. I mean, not perfect, but nice flow, no dissection.
Okay, ready? Go.
Very angulated. But let's dial it a little more with this balloon. Yeah.
Now, do you need a protection of D1?
D1 has
no.
we go back to the D1 strategy. There is a very tight lesion in the D1.
Go.
Even too.
Yeah. And the D1 is a very large vessel. I think you need to go a little bit further more. Let's go a few millimeter more. You see?
No. Okay. You're good, SS. Good.
Okay, what we do is the technique, what you do, you go up with the balloon, expand the balloon to full pressure like 16 atmosphere. And then you go down to half. Purpose there is that you want to get a good balloon-like, stand-like results. You crack the plaque at your 16, 18 atmosphere and then go down half about 90 seconds. But that way, you are taking up the dissection. So otherwise, continue high pressure, which propagate the dissection. This way, you tack it up and then, but have to leave it a little longer. So that's what we have done. Our goal here is, let's get a stand-like results in this D2, which was subtotal to begin with. And we saw it after. Look at that. See? Classical.
Yes,
this is where, this is a technique which I started many years ago and works very, very well. Okay, now let's go to the caudal view and then to really look into the
Can you move the
D1.
camera?
Here, go to this view.
No,
This
no,
view.
We never
26,
took a
26.
caudal, so you can see the ostium of the D1 well. Oh.
No, this is the one. Best
I
is
cannot
26,
see the
26.
No, you don't see the ostium.
No, you will
Now,
see.
no. Now, hold on.
Good. Yeah, that will be good. You want to magnify? Yeah. Let's see the D1 ostium. Otherwise, we go to our original view, which was good.
I think it looks good. Just stand across everything.
No. There is a proximal disease. There is a D1 disease.
Proximal disease.
Yeah.
No. I mean, LAD prox has disease. We know that.
Yeah.
But I'm
So
saying,
no, but here, see this one now. There, do you have another view? The D1.
No, I don't think the ostium of the D1 is involved.
Okay.
There's
but
a disease a little further down, but ostium is okay.
Yeah, ostium is not more. This
but
is
which way you want to do mini crash? We do.
Okay. Then we will go
Let's
to
compare
D1.
side.
D1.
I will take this wire out.
Yeah.
I will wire the D1 to the
D1.
fielder.
Yes.
And then we do a mini crush from
Okay.
D1
We have
to
the fielder
LAD.
ready. Yeah.
So now the D2 wire is coming out.
Yep.
We're
It's a
done with
long
that.
wire. Yeah.
Now we will wire the
Yeah.
D1.
Yeah. We have it. But I think go
Question
to
is
the
which view?
26. Yeah. Same. I think 26 view is very good.
This guys, what is this broken wire? Give me a new fielder.
How about protecting D2 and not D1, because D1 is not diseased at the ostia.
Yeah, but I mean, I think it's just getting there. Remember, let's take another picture now. Give the nitro. And let's take another little magnified view of 26, 26. So it is not, but remember, it's very close. And our stent has to come to that level. So let's say 1 second. RAO caudal. Good. Okay. Yeah. Let's go now. I think this will be the time also. We do the put a wire into the diagonal if you need, and then do the IVUS, which will tell us about the calcium and everything else.
Yeah.
Yeah. We do the IVUS also. Anyway, put a wire in the diagonal and then do the IVUS. Or do you want to IVUS now?
IVUS of what?
For the left main, just to, I mean, for LED, to see how, where is that calcium? I think learning, there is a dissection channels now. See, that was subtotal lesion has created some dissection, which is good. That means the plaque has been cut, which is fine. Yeah, I think one less mag. This is too big. Yeah. Okay.
Okay, this is a killer view for the interventionalist. What we call. Okay, so this is a fielder wire into the diagonal. Huh?
Yep.
It's a big
Okay.
vessel.
Yeah.
But-
And we are 2.5 balloon. We can use that. But
Good.
let's do the IVUS first of the LED.
Why?
Now, this will also tell us whether ostium is involved or not.
No,
And-
for that you have to go into the diag if you need to know the ostium.
Okay. Okay.
Would you like to see that D1 lesion? It's not osteal, so
Yeah. So we are doing the, you know what? We are doing the IVUS now. And that will be a very good one because we had the IVUS ready and not clear with any of these views. See that? I think it looks like there is a little bit of gap. The question comes, if the gap is less than 5 millimeter, should you cover it or you leave it? That's where the question will come.
Right.
In the lengthwise, right?
So IVUS is running through.
Yep.
So we are doing the IVUS from the prox LED
LED?
to the D1. Yeah.
D1.
Yeah. This is going into the D1. You'll see there.
Good.
There's a
That's
lesion
it,
at
yeah.
this level, so we can pull back.
Okay, start
Yeah.
pull back.
Don't.
Okay.
Yeah, normal part is coming. Like 3 vessel. No plaque here.
Just in it.
Yeah, here's the
Okay.
fibrous block.
Okay.
Yeah, here's so tight. But
That's
not
the
so much
lesion.
calcium. Yeah, a little bit 1 current calcium. Still D1. Come
And
to
that's the ostium.
Yeah,
Ostium
That's
is
the
okay.
ostium.
come to the
Ostium is not
LED.
No, no, but ostium is okay, but what length
Yeah.
between ostium to the significant plaque? That is what we need to decide.
Sure.
We knew angiographically that ostium was okay. The question is, what is the gap? Is it 2 millimeter?
Sure.
If you 2 millimeter, you are going to put a stent.
Osteal
You
lesion.
definitely will jeopardize. So let's learn from our IVUS master.
Like, okay, Dr. Sharma, like about 6 millimeter from the osteal D1 to the proximal plaque. And now I see the proximal LEDs also looks tight, very eccentric.
No, we are going to cover
That-
the prox
that
LED.
we know.
Yeah.
Don't worry about that point. We know that there is a tight disease in the proximal LED also.
Yeah, but
But-
it's a not calcified lesion.
Huh?
Just I see the deep calcium, but not superficial calcium.
Yeah, we understood that. So we knew by angiographically also that it will be a deep calcium we saw in the adventitial wall.
Alright.
So now, Kiski, we have very specific question.
Sure.
In
He
the
said
diagonal,
6 millimeters from the diagonal ostium to the lesion.
yeah.
Sure.
So question is from the tight lesion of the diagonal and to the ostium, how much is the length which is free of significant disease or there is some disease there?
Sure. It's like I said that like 7.5 is a diagonal tight lesion to the osteal diagonal.
What? You see?
Yeah, this is the tight lesion. Come to the proximal. This is the osteal D1.
7?
7.
Okay.
Yes.
So-
7.66.
Okay, between 6.7 to 8.
It's about the same. I mean, it's a little more than 5 millimeter. The question is, let's find out. Give me opinion. Give us opinion. We could go either way. What do you think we should do? Do a mini crush or 2 separate stents? The diagonal is very, and you saw that D2, I think D2 has been taken care. See the D2, I made a
Yes.
stent-like results.
Yes.
Yes, sir.
Inflate balloon to the maximum pressure, 16, 18, go down to half, leave for 90 seconds. Majority of the time, you'll get the results like we got here. So now second question, we want to ask your help as well as our audience that do you want a mini crush or 2 separate stents? So Anil, what would you do? Yeah.
Mini crush will be better, sir, because exactly 5 millimeter
275, 16,
it will be difficult to maintain
3538 promos. Yeah.
while doing
Okay.
it, while doing the stent.
Okay. All right, Vedanti, what would you do?
So even I would prefer mini crush because then the osteal we'll able to protect the diagonal ostium better that way. With the intention, we'll go with the same intention to protect the diagonal ostium.
No, what's the diameter of the diagonal? I'm taking a 275. 275, 16? Yeah.
Yeah, ostium is like average is 275. You're right.
LED is 40.
LED is follow. Yeah, true.
Okay, then 4038.
Yeah.
Yeah. Okay,
Okay.
can we put LED diagonal mini crush on the side?
Now we going with our bifurcate 3D and they're going to put those now. Pablo, find out room 6. What's happening?
Andrew, is he there? Or 4038, yeah.
Yeah. So we are putting a 2.75.
27516 to the side branch. Don't connect here.
Good.
Why we
Good.
do this?
Go.
Connection. And then we are going to 4038 to the LED. So always go to the side branch. Right.
Is it good enough? Lengthwise?
Probably just okay.
Yeah,
Yeah.
okay. Good,
Okay,
good.
good.
Yeah.
Give me the white one. This is a side branch, and then 38 to the main vessel. Okay, good.
Good.
So the main vessel is a
So the mid to
thing.
distal LED lesion.
Yeah, there is another.
Mid to distal LED lesion. What are your assessments for that lesion?
Minus. Go to minus. Okay. Yeah. Yeah, so I think there's a lot of
That
diffuse
could be-
disease.
No, it could be wire bias also
Yeah.
on a moderate lesion.
Yeah.
Yeah.
Okay.
Yeah.
Yeah. You see that? It could be a little bridge. When we go back to the original picture here.
Yeah.
You
Very
see that?
touch. Yeah.
It's
Yeah,
maybe
it's not
30, 50 max, but right now, you know, the wire has created
Yes,
some,
yes.
Wire
yeah,
bias,
yeah,
yeah.
bias. So that one, those things will leave it alone.
Yeah. And if
Okay.
really, you are concerned, so in the end, we can do the FFR. And that's the kind of case you decide that if you need to intervene on that moderate lesion. Because here it's already complex, LED diagonal taken care, D2 PTCA, and only the, I would say based on the FFR guidance, if you need to put a stent, then you go further.
Okay, sir.
Higher bias will affect
you hold it.
FFR again.
Hmm?
Wire bias will affect FFR again.
Yeah, that is true also, yes.
Okay, now some down.
Otherwise we'll do FFR with Gladius Mongo.
Good. Good.
We are good,
Take a
right?
picture, yeah.
Okay. Go.
You can pull back 1 millimeter. The promus, these are
We are
the
good.
two
I think
promus
we are good.
stents,
Yeah,
okay?
go up.
I'm going with the diagonal now.
Yeah, okay.
Yep.
So it's 1 millimeter sticking in the LED. You can see that.
Yes.
Mm-hmm.
So it's a mini crush. You don't need more than that. So he went up 27516 in the side branch, and that's how it is used. Can we do the mini crush of the non-left main? Okay, I'm going to take out the balloon. Before you take out the wire, puff. So you see, no need
Little
to take
puff.
an angiogram. Looks good.
Looks good, yeah.
So now I'll take the side branch wire. Okay, just make sure LED is good. We're
Yep.
covered good. Some
Yeah.
dye, some dye.
Yeah.
I just want to see. Okay, good. Okay, let it play. Yeah, go up, go up. Yeah. Mm-hmm.
Good.
Down.
Negative. Go up again.
These apps are so wonderful.
No.
and so
Hello. Yeah.
much
But
of
this is,
learning.
guys, this is not mini crush. You're not showing mini crush.
And to show the mini crush, these apps are so useful and we got so much accolade
Absolutely.
from everyone on those.
Wait.
1 second, wait.
Wait.
Something, don't pull yet. It's a long balloon. It will take a lot of time to deflate, even if they diluted the dye. Good. Get a 4020 balloon also. Yeah. So always when you are taking this double balloons out, make sure you are not de-air it. Actually, should de-air properly, and there may be a trouble otherwise. And then don't, when the equipments are there, that time you don't aspirate, because then otherwise you'll always get into trouble. Okay, let's take a picture now. Good. Looking good so
Excellent.
far. Yeah.
Yeah.
Okay, let's wire it now. So we have, what balloon we have now for the diagonal?
I mean,
Yeah, we had 2.5.
we have a 2.5.
Yeah. Are you in 2.75 compliant?
No, I think if you have to do it, then you have to do 2.5 first. 2.75 compliant may not make a thing into the diag.
Okay. Okay, this is the same fielder wire. We are going back in.
I would try
Good. You want to get the balloon now?
2.012 you have? Give me a 2.012 and then we go 2.75 high pressure to the side branch, 12. Is it playing? Mini crush? Okay, now we have the mini crush that's playing. The steps of the mini crush. So always place the side branch first. We are not a proponent of a pot in non-left main, and what we are going to do is, once we do the kissing, I'm going to do imaging and show you that the LED is fully opposed. Compared to the left main, side branch, we may not, yeah, good. You see that?
Yeah.
So this was a 2.0 balloon and just little bit of jiggling, okay? Just a little bit of jiggling. Don't be too aggressive. If you're too aggressive, the guide will come out, wires will come out. So just a little bit of, now if it did not go, I was going to ask for, we already have 4.020 balloon, then use 4.020 balloon in the LED and do anchor.
Yep.
So now this is done. We created a space and now I will go with the 275 12 high pressure balloon to the side and 4.0 into the LED.
Yep.
There is a high pressure balloon.
Yeah. Okay.
Now, if there's any questions, they can put it in the chat box.
Yeah. Chat box is not showing any questions yet.
Okay.
Yeah. You.
Could you please be little elaborative about your that anchoring technique again?
Okay,
In case
anchoring tech, yeah, what I meant is suppose my 2.0 balloon would not have gone into the side branch,
Yes.
right? The reason why a 2.0 balloon will not go. So you may have to change the rewire again, go to a different strut. That's one.
Right.
The two things, let's start from the beginning. One, wiring. Okay, I know there's a lot of theory saying you have to go to the proximal strut or the distal strut. I'm not a believer of that. As long as your wire goes through a strut, you are okay. Here, once you have recrossed, okay, wire has gone, then you try to balloon. You saw that there was a little problem. If it had not gone, two things you'll do. First thing you'll do is rewire in a different strut. If you rewired and still it's not going to a balloon, then you do what's called as anchor. I'll show you what is anchor technique right now. So give us that. And also, if Andrew is still there, you can show it on the 3-hour app also, how anchor technique is done. And I'll tell you what happens. So as you're trying to, like I showed you, jiggle, you see that the guide comes out, wire goes forward. And what anchor does it? It holds the guide.
Holds the guide.
At the ostium, and you are able to then navigate the balloon into the side branch. So I'll show you what is anchor technique now. So this one.
I have to advance the wire a little bit more.
Yeah, I will.
Yeah. Yep. Good. That's fine.
That's good.
We can leave it there. Yeah.
Maybe in the some septal.
Yeah.
So now you see what we'll do. So you need a balloon, distal part of the LED. Now we have enough stent length here, so we are okay. If the stent, I'm saying was, what if it was a 28 millimeter stent? You can't put a 20 balloon distal, then a part of the stent will be in the native vessel. It's okay, but go maybe 6-7 atmospheres.
Then you go to a smaller, the shorter balloon.
Shorter balloon.
Would have been,
Good.
Yeah.
You anchored?
Yep.
More, little bit more.
Yeah. Good.
So now see that? You have it there. Good. I'm going fluoro to show you. Now I'm getting into the, see? Yeah.
Good.
That's how we'll get the balloon in. That's called anchoring. You see that?
Anchoring. Yes.
And you, I don't know, he can show it to us. So now go up. Deflated. Okay, LED deflate, no need to cause ischemia. So what you'll do is once you're there, this is a 275, go high pressure, maybe 1820. So your ostium is fully
Well played.
dilated, well done.
Good.
And now what I'm going to do,
In the
LED.
kiss.
Yeah, bring back. Now first let's just dilate the LED here.
Yeah. Go up here,
Good.
LED.
LED, let's post.
20 atmosphere.
No, need 20. 16. 16 is good.
16, good.
Good. Down. So now we will do the kissing balloon.
Good.
So lot of people, what do they say is that when you do a kissing, that it becomes oval.
Go.
You have to do part, then it becomes circular. This is all theory. There is no. Okay, good. It's too much.
Yeah.
Down. I went like.
Yeah. 18. So the diagonal was 18 and LED was 16.
You don't.
And remember, the pro pot trial itself was not positive in terms of the mal opposed struts or any. So key is that in the left main, I think that makes
ready?
sense. Yeah.
So,
Iwas is ready. I mean, look what you did.
Yeah. Good.
Actually, as Dr. Annapurna says, I also don't believe in which strut you cross. I think the best strut is where your balloon goes easily once you cross with the wire.
Yeah.
I mean,
or with some small struggle, and that's the best strut, I think.
Okay, there's a little bit of dissection proximally, but let's see is it significant or not. We'll decide by the IVUS. Go to the IVUS.
So very clearly we have mentioned in the app, you cannot go more than 16 atmosphere. You do individually go high pressure. When you kiss, you don't have to go that high pressure. Because this is what happens then.
Little bit of the question is it because of the, remember that happened the proximal edge of the 4O. See, it's only proximal. The second one did not come to the proximal.
Does not matter.
You see, it's a proximal, but that is not uncommon. You know, patient has a disease, mild dissection, we know, they are okay. But anyway, is it more significant? That we'll figure out now with the IVUS, yeah.
So when we are recrossing, it's very challenging. Okay, recrossing itself is very challenging. And then now you have to, on top of that, you have a secondary equation that you have to go proximal strut and distal strut and central strut.
It's all optimal crossing is the best word.
Yeah, optimal crossing, that's the word, yes.
And once you
Okay,
cross
I'm going
in
to
your
the distal edge.
Yeah.
So this IVUS is going to tell us that we don't need to pot in non-left main.
Still native. This is getting bigger. No plaque here. Still native. Yeah, perfect. Distal edge, perfect. Really expanded. Normal position.
Perfect. Perfect.
Now I see the septal and the D2. And this was the subtotal region. Yeah, I see the outside plaque, but stent is well expanded.
Well expanded.
Yeah, looks good.
Area is
Good
still
little flush.
No.
You have to do some flush.
No need. You see it.
Now it's 4.
Maybe. Now we see the side branch. Yeah.
Yes. You see that one strut that has of the side branch? Good.
Yeah.
Yes.
And look how beautiful, circular and well opposed
Yeah,
proximal LED is.
True.
LEDs.
Okay.
Yeah.
I can
Okay.
check detail.
No, we didn't see a dissection.
Okay.
Yeah.
On the IVUS.
I will stop it.
Yeah. So
Good.
that's good.
So now we need to go to cranial
No, you
to
want
see
to do.
to see that LED lesion. How does it look?
Oh, you mean the proximal lesion?
Mid? No, LED distal. Remember that which looked like a moderate lesion before? Yeah.
How are you at the proximal edge,
Yeah,
Kiski?
just on the plaque, but not the section.
Okay.
Good.
So what Kiski is saying that the stent has landed on the plaque, but no dissection,
Yeah,
which
true.
is good. But more important is without pot, just by kissing, we're just showing that in non-left main, the good expansion of the LED stent.
You won't take the diagonal wire out?
Okay.
Yeah.
So there are some questions
Okay.
with your permissions.
No, we want to answer those questions.
Wait,
Yeah.
1 second.
Let's take
Yeah,
this
yeah,
picture.
So
Let's take a picture.
now the question is on the second thought where we should be doing two separate stenting without involving the diagonal ostium. So could you please tell us your views about it? rather going for a mini crush, what if we do separate stenting for the diagonal proximal lesion and the LED?
Very good point. Yeah. So clearly, I mean, clearly, as we said, if the limit, what we say that if there is more than 5 millimeter room, I mean, this was about 6, just barely. So I would say the safe will be about if there is a 8 millimeter disease-free area, then you don't put a mini crush or culotte or double or the DK crush. But if it is less than 6 to 8 millimeter, it's better to do a mini crush like we did in this particular case.
Okay, sir.
But otherwise,
So
you put a stent in the diagonal, then stent in the LED, and then don't even do a kissing. At that time, don't even do the kiss.
Okay. There is one more question about this pot. That why not pot in the non-left-hand?
Yeah, so we talked about that. So that that lot of people are pot. The question is, where are the data from the pot? Lot of the shown on those ormestra, I call it ormestrography, ormestan, that it looks this, that, but where is it in the patient in vivo? We don't have much. We know that there is only one randomized trial, ProPot, and ProPot basically looked at stent expansion and how is the mal-approach struts, and basically actually was they even trended towards in your kissing balloon better compared to pot. So that's our strategy. So basically we'll do a kissing balloon like we did in this particular case. We definitely will do a pot in the left main because of the size disparity. And then of course you have to have a little more longer stent in the left main so that you can expand at least have a 6 or 8 millimeter balloon to accommodate. But otherwise we have and then a lot of people will do pot, kissing, then repot. And this question comes up. Actually, we did a case last week in our last month in our CCC live, and I'm so thankful to our Indian audience, which is second after USA. About 30+% of our audience of 18,000 are from India. America is around 40%. So they questioned that why did we not do a repot?
Slide.
Yeah. So
and
we
our OCT imaging that we showed.
Right. So repot, and so we actually have done the OCT also, and more importantly with the ProPot trial, that there was absolutely no difference. I can just show that data from the trial. But just to say, now question is, once you have done the pot in the left main and you have done a kissing balloon, do you still need to do a repot? I personally think not necessary. I think it has been just over exaggerated that you need to make more circular. But to me, you have done a pot, you're kissing, that actually is very good. You don't go to very high pressure as Dr. Keeney mentioned, the 16 atmosphere. Individually, you can go to high, but when you are combined, about 14 to 16 atmosphere will give you a good stent expansion and apposition. So therefore, the pot was not indicated in this particular case, and we do not do it in our lab. Now, some people will do a
lot of imaging, and we ourselves have published on OCT showing that you don't need, we compared, when we did pot versus just kissing balloon, there was no difference. And that is the only published data of the Vivo. And then the other published data was the ProPot trial. Both of them are saying the same. So why, the question go back, why? Why? Very important. These are complex procedures. So you need to decide, I'm doing 2-stent technique and these are my steps. So when you are doing these steps, you see that, okay, wire goes into the side branch. You have issues going into the side branch. Now you're struggling to get into the side branch. So a lot of things could happen. So the question is the same. Do you want to finish the procedure, complex procedure with the steps 1, 2, 3, 4, 5, 6, or you want to keep adding another 15 steps, make it complex and have complications? So that is where it is. At the end, the results are good. Patient outcomes are good with fewer steps, less dye, less radiation. So these are the outcomes we have. The outcomes are very good. So if the outcomes are good, so what we say is very simple, that you become proficient in one particular technique and just keep doing the same technique and you get better at what you are.
Okay. So there is one more question, ma'am. Dr. Abhishek wants to ask, why not DK crush in this? Why not DK crush in
Yes, DK crush also, again, I said you will probably add 6 more steps in the DK crush because
Right.
you have to crush it. Okay.
Crush it.
Now again, those guys who are gung ho, now they will say, I want to go to the proximal or the distal strut. Then they will do imaging to understand, am I in the proximal strut or the distal strut? Then you will do a kissing balloon. Then you'll place a stand. Then you recross, right? Then they will say, we will kiss again. They'll pot, then they'll kiss, then they'll repot. Look at the amount of steps you have. And at any time, wire entanglement, things will not go. You understand? So every time you have a
Yes.
problem, what is the biggest issue? Your wire, distal wire can go way further down, risk of having thrombosis or wire perforation. So that's why I'm saying that if your outcome, what is the thing about DK crush? You know, we always say yes, somehow yes, but the DK crush was first started in China. Outside China, we don't have any results of DK crush. And here in Sinai, you have seen every live case, we have shown how to do mini crush with fewer stents with great outcomes.
Right, ma'am.
And the key
there is
our biggest region not to DK crushes and do a mini crush. By mini crush, you avoid at least 3 steps of the DK crush and less struggle. Now, I would say that only if you say, well, Dr. Sharma, what is the true advantage of the DK crush over mini crush besides having a 6 or 7 French? DK crush, you can do a 6 French, mini crush, you require 7. The ostium of the side branch, maybe slightly, maybe. I still don't have clear-cut data, but there seems to be, based on the literature, the ostium of the side branch may have a little better minimum stent area in the DK crush compared to mini crush, because you open that before you put an additional metal. So that's a theoretical, but if somebody asks that, tell me a one clear advantage besides the 6 versus 7 French guide that the DK crush has, that may lead to slightly lower restenosis in the future. Now, we have a lot of data of the mini crush, again, the TAP, again, provisional stenting, all showing better with a mini crush. Complex intervention, better to use 2 stents versus single stent, which we have shown by various trials. That actually, coming back to the complex cases, go with the plan, 2-stent approach. Don't worry about the wire, where the wire goes. As long as the balloon goes, you do a dilatation and do a kissing balloon. If non-left main, you are done. And we have proven there. We have shown this today by the IVUS that how circular proximal stent in the left LAD is. So just wanted to go with the pro pot, show that slide.
One other thing, total dye use was 140 seconds and fluoro time 15 minutes, air karma of 1.3. So here in New York State, for every patient, the radiation dose has to be reported to the state. Anybody goes about 2, about 5, about 10. So we are very, very cautious about the dye use, very, very cautious about the radiation for both the patient as well as the procedure list, because, you know, you keep doing this kind of complex procedure day in, day out, there's a lot of radiation exposure to the procedure list.
Yeah, so this was a randomized trial from Europe. Yeah, so just to say that compared 120 patients to pot group or kissing balloon. And you can see there, basically they followed the patients and they have various attachment. I mean, various, would say that pot, repot, side branch, kissing balloon, and all those. But overall concept was do a pot versus kissing balloon. And this basically was a trial. They actually showed what it basically means, what pro pot was, and then how you're going to do in terms of, and then did the OCT analysis. Now, these were very few calcified lesions. Truly, they were bifurcation lesions. And so procedure time, pot, the kissing balloon dilatation, wire recrossing, and overall amount of contrast in the pot was much higher or trended towards higher compared to the kissing balloon dilatation, slightly higher procedure time. Now, most important is this, your post-procedure instant. And you can see there, exactly identical in pot, kissing balloon technique, MLD of the pot and the side branch, absolutely the same acute gain. And so then these are the instant, then proximal edge, bifurcation, and all those things all actually say clearly that of course you improved from pre to post, but from the kissing balloon versus pot, there was no difference as shown in the bottom. The stent and lumen area, stent area, exactly identical. If you think about in numerically, everyone you have a little more positive on the kissing balloon compared to the pot area. So that is another important idea was, what about your malapposed area? And you can see here that the overall dissection, the coarse proximal malapposed, maximum malapposed were both all identical, except that there was a coarse distal malapposed with a higher with the pot compared to the kissing balloon. So, but I think overall, in my opinion, there was no difference between two techniques, and this is basically 1 year outcome was absolutely no difference with the TVR in the pot versus kissing balloon dilatation in this randomized trial. And they actually, author made it center figure that raised by final endpoint at bifurcation. Yeah, and jailed strut bifurcation, all those were no different kissing balloon versus pot.
Where's our, you don't have it?
Yeah, but that's fine now. That's okay. Yeah. So we actually have shown our, we have also the post-pot and data. But with that note, if everybody is okay, we conclude our today's live presentation. And we are ready to have our discussion. And I will join you. Unless there is any other question in the chat, you can ask us now. Otherwise, we just conclude the live relay. And soon we, and you can start your case presentation. I'll join you in a few minutes.
Congratulations, and Dr. Annapurna. It was a wonderful case, so much of learning, and so many people watch your videos and your apps, and they are so teaching material for everybody in India and all over the world. So thank you very much.
Sorry to interrupt. There is one more question from the audience. As they say, is it necessary for every bifurcation stenting that we do IVUS?
Not really,
Yes.
but left main, yes, definitely. For left main, you have to make sure, you know, there are a lot of outcomes related to that. You have to make sure your final opposite is good. But for a non-left main, we don't routinely do imaging.
Yeah.
No.
Okay. Thank you
Thanks
very
a
much.
lot.
Bye-bye.
Thank you.